The next Paris Tekkis needs no introduction. You've already heard a masterly presentation from him. And now you're going to hear that even he is in sympathy with all of us who actually think not operating sometimes is a good thing. Paris.
Thank you, Bill, for this introduction. It's interesting that I'm going to give you now the different side of the coin and see how we can disagree now on what we do. And I'm sure that's why you asked me to speak after the French view, which we get on very well. So the question is, how long do we wait? And what you've got here, the tumor, and you see this bear is waiting to eat this one. But do we wait 6 weeks, 12 weeks? Do they wait indefinitely? And let's see. So these are some of my better images stolen from Gina. And we basically got a tumor here. And this is the same slides, obviously. We've got the tumor, we've got something on the outside. I'm not going to argue whether it's a lymph node or EMVI, because I want to upset her now. So, so whatever it is getting smaller. And it's going more black. This is the surgeons understand gray and black. When it's black, it means it's scar tissue. So is this a viable tumor? Do we operate at this stage? Because standard treatment is that after 6 weeks, we do chemoradiotherapy, we operate. And that's what it's been up to the present date. We then, we're thinking, what if we operate at 12 weeks? Here's the scan of 12 weeks. And it's tiny, I don't know how well it projects, but essentially it's all turned black. So do we operate now or do we wait? And obviously on this one, we waited, and that's basically the next scan at 18 months. Again, this blackness is still there, so and how long do we wait? That's the key question. Do we defer now, and how do we follow up if we decide to wait? And that's what we call expectant policy. So we have your staging, and I think, Gina, if you're going to leave this one, you have to make a decision when it's going to be N1 or 2 and N plus, because it's there. Don't shake your head, because this is what you've published, so we need to decide what we're going to do about it.
But you haven't looked at the latest publication.
Yeah, send me the slide, and I'll actually put in the new slide.
Yeah. So
something has to be done about this one. And if we look at now the surgical, so the Dutch surgical colorectal audit, which is an important paper. If you look at the response to treatment, these are the PATCR patients, and the optimal timing of this manuscript was that at 14 to 16 weeks, the plateaued off. So essentially, you get better and better in terms of regression, and then you stabilize. If we look at now the American view on Julio Garcia-Aquila, we have the chemoradiotherapy followed by surgery. They had an 18% complete response to treatment. If you are 2 weeks of FOLFOX, you get to 25. If you go to 6 weeks, you get a 38% complete pathological response. So the question is, do we throw everything up front? Yes, Gina, look, this is what he's trying to tell you. The other extreme view. Not just it could be an early tumor, which would actually throw the kitchen sink at it. So you throw the chemoradiotherapy and full chemotherapy, as the Americans are going. So you use a 40% complete response. You see here they're getting anxious. So we're going to get more anxious in a second. So this is what is going mad, because the more choices we have no control as to what is going on and more confusing. But let's try and make some sense. We've got the 6 versus 12 trial, which is our trial from the Royal Marsden Hospital, where it was an international multi-center randomized control trial. We're looking at patients who are more likely to respond to treatment. And these were MR-defined poor risk, CRM threatened, low rectal cancer. They were T3C and above. They were EMVI positive, and they were N2. So they were randomized then to go into a 6 weeks or 12-week arm, with an endpoint being downstaging in terms of a T stage. The key here is that at 6 weeks they received an MRI to identify the good responders and the poor responders. And if you are a poor responder, you instantly have your surgery. So you don't wait until you get your meds and then you operate, which is different from the French trial, which I'm going to be discussing in a second. So at 12 weeks, the downstaging in terms of MRT downstaging was 43% at 6 weeks, 58% at 12 weeks, which was statistically significant. So we do get a downstaging of the T if we wait longer. And then we have the MRTRG, and Gina keeps on saying 1, 2, 3, 4, and 5 is poor responders, and 1 is you got a complete radiological response, which doesn't always correspond, obviously, to a path CR, and we'll come to that in a minute. This is radiological TRG1. So if we look at this tumor, it's gray, that's seminal vesicle, you have the rectum here, we've got the holy plane here, and you've got the chemoradiotherapy is turned black, is away from the seminal vesicle, there's fibrosis, so there's 50-50 chance that there is viable tumor there, it may not be viable tumor there. But we can differ because here we've got an excellent response to treatment. So if we look at now at, in terms of the MRTRG1, which is total complete response, it was 6 weeks at 6% at 6 weeks, 22% at 12 weeks. And so we had almost 50% of the patients were TRG1 or 2 at 12 weeks. And 4 and 5, you can see here the results. So we are getting a better response to treatment if we wait longer. And this is the pathological CR. Now, Y means they had chemoradiotherapy, pathology, complete responders, 24% versus 11%. And this is the T0 and 0. You can see the results which were significant. So the quality of the surgery, how good are we if we go in at 12 weeks? Do we compromise? And if we look at the complete, near complete and incomplete TME, similar results. And what about the complications, which is different from the French trial? If we wait 12 weeks, we have no difference in terms of morbidity compared to 6 weeks. So wound infection, similar, anastomotic leaks, 11%. And you can see here the whole endpoint is the same. So if, in conclusion, the summary is that at 12 weeks we had increased T staging, we had a favorable increase in the TRG1 or 2, we had a CR which had increased, and we had no postoperative change in the complication rate. Obviously this has to be balanced between the quality of life, which is what we've been discussing earlier, and the risk of local recurrence and distant meds. So what is the optimal timing now? If we respond, we could wait up to 12 weeks, but can we wait any longer? So what's the problem with the French? So just to upset you both. So the French problem is that they were comparing 7 weeks versus 11 weeks, whereas we are comparing a longer interval. So you get less downstaging if you wait 4 weeks as opposed to 6 weeks. We've included high-risk patients, where the French study was looking at early disease. The problem with early disease doesn't respond as well as the high risk. So if you select the high-risk patients from the, and I see Rob is disagreeing. Actually, the Dutch study was showing that you have a higher probability of having a better downstaging if you select the poor tumors rather than the early disease. So the benefit probably is diminished if you're just looking at early disease. But the most important factor is this, that we were actually using a mandatory MRI to identify the poor progression. And then we actually siphoned them off to the intervention arm, whereas in the GRECA rate, there was no restaging after chemoradiotherapy. So there was lack of information to guide the surgeries to what we do. So they had a higher morbidity, whereas we didn't show any difference in morbidity. We also gave more radiotherapy. So was this a high dose response that we've seen, actually what we've seen in the UK and the French trial? I'm sure we'll be discussing this in a minute. So what do we do now? Because not all tumors behave the same way. With high-risk tumors have more to gain by downstaging. But when do we operate? Now, this one, what upsets Gina and Bill is that we've got an early tumor, SM1, 3N1. You have primary surgery, you do a local excision and chemoradiotherapy, or you give preoperative chemoradiotherapy in this stage. It's an unanswered question, and we've got here ethical issues because some surgeons prefer this, like Bill will go for surgery, some other people will use chemoradiotherapy if you are in Brazil, for example, and Gina is advocating this one.
No.
Well, we'll see in the long run. So this one, for example, is here your slide. Well, your AP, you can give chemoradiotherapy, and after you've given chemoradiotherapy, it's completely gone.
Yeah, that's the point. That was our MDT decision, which I was showing the scans. The margin was involved because it was a close TME claim.
Yeah, but this one actually got into complete response.
He did.
Yes.
And every time this kind of low tumour bordering the intersphincteric plane, we would give chemo-RABs to. You know that.
So TRG2, actually near complete response, we can give chemoradiotherapy, and then they actually respond to a full response to treatment. So our criteria for going into deferral, so waiting beyond 12 weeks, they are here, you can see them. So we've got TRG1 or 2, and then you have thickening of the rectal wall, you have an abnormality on the endoscopy, you have the palpable tumor, but you are allowed to wait, because we know that up to 16 weeks, there's no problem if they've responded. There is a problem if they haven't responded. So we've enrolled over 100 patients, and but you have to actually have some form of a protocol, because then somebody has to be responsible for picking up the tumors when they regrow. And I'll show you that from the international watch and wait study, the regrowth rate is 25%. So this is an intense protocol. You have to follow up to 5, 6, sometimes you might think up to 10 years. The next question we have is that can we use the radiotherapy to guide our treatment? So if they've responded, then we go back to the what Quentin was saying. Do we go for a watch and wait, or do we locally excise? And we've already discussed GRECAR2, but I'm going to show what I didn't like from the GRECAR2, so we can then have more discussion about it. We saw this one earlier on, how they were randomized, and I'm not going to repeat this one. So these were discussed previously. The endpoint obviously was the composite of death, recurrence, major morbidity, and the side effects. And the biggest problem when it comes to local excision is compliance. And the French study had a 50% non-compliance because the surgeon wouldn't do a complementary TME, and then they started local excision, 99%, yes, I'm fine, happy with it. But primary TME, the compliance went to 85%. When it came to complementary TME, it's 76%. My problem is here, if you had chemoradiotherapy, you've done the local excision, what's the effect, long-term effect of having done the salvage TME or complementary TME? It's the same thing in my mind. In terms of long-term results, if you do a local excision or a TME, you have the same. They are exactly the same survival. And if you look at this 3-year disease-free survival, overall survival, if you local excise or if you do a TME. But the problem is this: if you had chemoradiotherapy and you do a local excision, these guys who are then have to have a complementary TME, they are doomed, because you have a 78% major morbidity or side effects compared to a TME and a local excision. Here are the complication rates, 50-50 instead of 12 and 22, and their late morbidity is 1/3 compared to these two. So you're making a compromise by doing a local excision, and you're compromising their quality of life indefinitely. And how do you compromise it indefinitely? Permanent stoma rate, 25%. And the same survival. Sexual dysfunction, 40%. Pelvic abscess, 30%. So if you're going to do a local excision with chemoradiotherapy, you better make sure that you get it right. Because there's no point just taking out for a biopsy, because if you're going to do a TME, you have a problem in the long run. And that's what we've learned, I think, from the French, which we haven't actually been able to show this in any of our studies. And that's why I like this study, because it's got a very strong message. So it showed that it's a fail to show superiority of local excision over total mesorectal excision. Now Gina will get upset. And then we need selection to avoid unnecessary completion total mesorectal excision. I'm not making this up. This is actually taken straight out of the Lancet paper as the conclusion of the trialists. So what if we watch and wait? Now, hopefully, this paper will come out, and we are not involved in the international watch and wait study, but I know the results, and if it gets accepted in the Lancet, it's going to be a landmark paper. But I can give you some of the provisional data. There were observational cohort studies from the 3 centers, Netherlands, the UK, which is Manchester. They submitted 140 patients in the territory around there, and the Brazilian data. And they were all observational. They have got over 1,007 patients on the registry to the present date. And the problem is that we're not going to get these published, any of these trials, so we can have some randomization to see how the watch and wait is affecting the overall long-term survival. So if we look at these 38 participating centers, 880 actually are the patients who they've submitted for publication. Local regrowth is 25%, and at 2 years is 85% local regrowth, and the luminal recurrence is 96%. So most of the recurrences will occur intraluminally, and that's why we cannot just rely on the MRI, which Gina doesn't believe me. We have to be actually looking at it endoscopically, because I can see with an endoscope when the recurrence comes, even if it's actually 1 or 2 millimeters. Because once you flick the MBI and you do a chromendoscopy, you can pick this up very early. And if you look at the overall survival, and median follow-up 3.1 years, at 3 years they had an survival of 91%, and if they had a local regrowth and they had surgery or some salvage, it went down to 87% 3 year. In the Lancet paper, hopefully they give us the 5-year overall survival. And if you look at the cause of death, 27% were related to the rectal cancer, 20% from another malignancy, and 50% it was others. So organ preservation, what do we need to do? We use time as a test to see whether there is any regrowth, and then do a timely intervention to salvage. Because if you do salvage, you can salvage them, and if you actually have a protocol and you follow them, and as soon as you get regrowth, you actually do your delayed surgery. This is the trigger, which I hope Gina will tell us more about this afternoon, because that's our way of looking at deferral, and deferral is here for the TRG1 or 2, and that to be discussed later for the interest of time. So in conclusions, we're looking at individualizing the cancer care, using the multidisciplinary team to identify which are the good responders, and if they are responding, perhaps you can wait longer, and if they are actually going to a point where they have a complete response, then we enter a deferral of surgery protocol. I do not like local excisions because of the problem long-term of a salvage TME being compromised. So that's my conclusions for this talk, and we can have a discussion over this one.
We obviously could now have a rerun of the Napoleonic War or of the English Civil War, and I think in fact we all get on very well with each other. But it is a very interesting diversion of a diversity of approach between the French, and I think Professor Deneau should have the chance to shout back. We'll let the Napoleonic War
We published together actually, so we are friends.
But not on this topic. So first of all, I would like to answer about your question in the previous talk. We perform proper MRI every 4 months in the follow-up in patients with grey card 2. So we follow the patient with MRI. Then we discuss about, you are right, and I presented the morbidity of completion TME after local excision. But what about APR in watch and wait performed after watch and wait? Because you have 50% in published data, because you present not published data. In published data, there are 50% of APR after watch and wait. I think that it's significantly higher for the morbidity.
Hold on a moment, you're talking about watch and wait in which surgery becomes necessary.
Exactly.
And that's only a small percentage for watch and wait.
But it's a small person, the patient with completion
and
TME after local excision, it's a really small proportion as well. So we have to take about the same cake, if I can tell like this.
I honestly believe this argument can go on forever, but honestly,
But it's an important point what he's saying.
Yeah, and the last one, sorry, the third point is, I'm sorry, you present because Gina Brown presented 2 years ago in the SCP the trial, 6 weeks versus 12 weeks. We are waiting for the publication. But I'm really surprised about the 1% leakage in the group of 12 weeks. How can happen?
No, it's not 1. I think it's.
You can go there.
I think it's a typo.
It's 1%.
It's the same. It's the same.
No. You
It's
put
the same.
1% Paris in your slide at 12 weeks. You say 1%.
It's the same.
It's the same. It's 11.
There was no
It's
difference.
11.
It's a mistake.
There was
Yeah, it's a
spelling
mistake.
error.
Okay,
Sorry, I
thank
did
you.
say it's a mistake.
Over to Gina, then she's gagging to answer that.
Where do we-
But we must understand that the watch and wait cases are predominantly very low because you get more, especially with conventional radiotherapy, you get more complete responses in the lower tumours. So you're automatically selecting ones that are likely to be getting abdominoperitoneals if they need surgery. Of course, half of the ultimate failures of watch and wait will end up with an AP.
I think what
Gina.
he's saying is very important. Is salvage TME better than APR following complete response? I don't have an answer, but that is what we should be thinking of in the long run.
So the whole thing is if you're looking at patients who've been irradiated because they've got low tumour, like the one that Paris said, of course, whatever happens to them, they're going to need an APR. Because in the beginning, they are a low tumour sitting right on, you can see that tumour sitting right on the sphincter. There is no sound reason to try and preserve the sphincter when it's sitting right on the sphincter and the surgeon has to get below it. Apart from, it's a coloanal anastomosis with all the problems that you see with that. So that's a different group. So as Bill said, if you're irradiating a group of patients who are destined for an AP anyway, sure, you can offer preoperative chemo-rad because they're going to need something to save their intersphincteric plane, and that's a different reason altogether. So we have to take those out of the equation. So what we're talking about, and my concern about this whole idea of irradiating early rectal cancers, is leave aside the ones which are facing an APE. Let's look at the ones that are in the mid and higher up. Because those patients, we already know from the vast majority of radiologists are overstaging these anyway. So we've got some early T1 tumours being irradiated on the off chance that they get a complete response. You do some sort of TEM procedure, which is like a biopsy. You find residual tumour, and then you end up having to perform a TME operation, which, as Paris has shown, those patients are getting a much higher rate of permanent stoma because of the complications.
So thank you. Last very short comment of Soren, very short.
The problem
And after we
is,
stop.
Soren is usually wise. Let's see what we're going to come up with.
the problem is very, very simple. Because if you give chemoradiation and you have to operate, the functional outcome would be worse. In addition, if you don't have to operate, you also get sexual problems and bladder problems. So we really, this must be done in trials where they really look into all these components. That's the way it is.
Okay, thank you. I think we will stop. Thank you, Paris.